Dr. Ammerling will help us introduce our speaker tonight. Thank you, Dr. Ammerling, for being here to help us. The floor is yours.
Thank you, Jeremy. Well, great to have you all here with us out there in cyberspace. You know, it's interesting, over the last several years of the COVID tyranny, several heroes have emerged. And what's been fascinating to me is that two of the major heroes of that movement are old mentors, friends of mine. I'm talking about Dr. Pierre Corey, who started the Frontline Critical Care Consortium. We were together at Beth Israel in New York. He was in the ICU. I was doing nephrology there. And also Dr. Peter McCullough. He and I used to run into each other on the academic lecture circuit because he was talking about the heart-kidney interaction, and I was talking about the kidney-heart interaction. So we became friends almost 20 years ago. And now that we're kind of getting through, hopefully, a little bit of this COVID insanity, a bigger problem is emerging. And that problem is the destruction of the medical profession by the Marxist takeover through what is called wokeism of medical practice and medical education. Several years ago, when I was still actually reading the Wall Street Journal, I happened upon an editorial that caught my eye. It was called, I believe, "Take 2 aspirin and call me by my pronouns." And I looked at the byline, and it was written by another old friend and one of my former mentors, Dr. Stanley Goldfarb. Dr. Goldfarb and I were together at the University of Pennsylvania Nephrology Division. I started there in late 80s, and he was already one of the professors there and one of my mentors. And we became friends and colleagues, and we've been in touch over the years. We would run into each other at the Penn annual reunion at the American Society of Nephrology meeting and other places. So when I saw that he had taken this stand, I was very, very impressed and proud, because Stan, to me, was always brilliant and a creative thinker and someone who was not in any kind of rigid box. He was always thinking outside the box and was a great role model for me in my career. So he founded this group, Do No Harm, to push back against this horrible woke agenda, which quite literally is threatening the medical profession. It is profoundly anti-scientific, it's profoundly unethical. And Dr. Goldfarb will get into that in some detail, and then we will have a Q&A period. So let me turn it over to my colleague and friend, Dr. Stanley Goldfarb.
Well, thank you very much, Richard. Those were wonderful days that we spent together, and I look back on them with great satisfaction. And thank you very much for that very generous introduction. I don't know how the old story is only my mother would believe it. So, but thank you again. Let me start from the beginning of how this all came about for me and for Do No Harm. So this began when I was the Associate Dean for Curriculum at Penn. I had been on the faculty there for many years, and I had done research and taught and was an administrator in various jobs, you know, sort of your run-of-the-mill academic physician. And then towards the end of my 13 years as being the Associate Dean for Curriculum, it became clear to me that things were really changing in medical education. And yeah, I should have been more aware of this, but you know, we were sort of living in our own little world there, and we were quite content with the way we were teaching medical students. Penn had undergone a dramatic change in its curriculum about 10 years before I started in my job. So I inherited a curriculum, and the curriculum had been a dramatic reduction in the amount of science that really the students were exposed to. And I always thought this was a mistake, but instead of the 2 years of preclinical science, the first year usually, as you all remember, was sort of basic ways that the body was structured and functioned. And then the second year was sort of clinical sciences. It had been compressed into a 14-month curriculum. In some schools, a 12-month curriculum. That always bothered me a bit, but you know, it was what it was, and we made do with it. A new vice dean for education, though, began at Penn, and about a year and a half before I finished my time as the associate dean. And she came from the University of Connecticut, had a degree in education, which should have been a red flag because education, schools and degrees in education, I think is Richard talked about the Marxist influence in American medicine, and that's a big sinecure of where Marxism thrives in America, is in schools of education these days. And what she brought was this focus on the fact that we must teach much more social determinants of health in the curriculum. Now, mind you, we had a pretty robust curriculum in social determinants of health, but the idea was to do it much more, to create student advocates for various social positions. And I thought this was rather strange because the last I checked, we really weren't able to do anything about housing problems or about food deserts or about community violence, despite what the American College of Physicians has claimed, that we be the gun control gurus in America. And it just seemed to me that I didn't realize how we were going to improve this educational experience for our students and teach them to be better physicians if we were going to spend all this extra time on advocacy positions. Right towards almost at the very end of my time there, and it was time for me to retire. I've been at Penn a long time, as you heard. I was there for about 30 years before Richard showed up, so you can imagine how old I really am. And a faculty member came one day and said that we really need to start teaching about climate change. And that was about all I could handle, because to me, anybody who talks about climate change ought to be an atmospheric thermodynamicist, because that's really what it takes to understand some of these issues. And it seemed to me so ridiculous. And as a matter of fact, I remember a line I said to him. I said, well, suppose we just have the climate of Miami here at Penn. Would that be so bad? He didn't really have a good response for that. So be that as it may, my time at Penn was almost up. And one day I saw in the Wall Street Journal that there was actually an article that said 40 medical schools were engaging in courses on climate change. And I wrote a letter to the editor saying this was ridiculous. I'm someone who used to write letters to the editors and sometimes get them published. And he came back and said he really wasn't even aware of this article. And I pointed out to him, no, there really was such an article. But he said, why don't you write an op-ed? And Richard mentioned that I wrote this op-ed, and the op-ed was simply about reducing the amount of time spent on these social determinants of health, because I felt like they really didn't contribute to medical care. I understood that there are social problems that various communities have to deal with. I just didn't see how physicians had any agency to deal with them, and that we should make sure that we don't. And really it was a message to not to expand it anymore, because I knew that the AMA in particular had a big push to push more of these social determinants of health. And this is well before the George Floyd killing or the beginning of the pandemic. So I wrote the op-ed, and as Richard mentioned, it had the title, Take 2 Aspirins and Call Me by My Pronouns. That usually elicits a chuckle when I tell people that. I wish I had thought of the title. I hadn't. The Wall Street Journal supplied the title. I thought, well, there it is. I got my ideas out there, and now I can just go away and disappear from view. Old soldiers never die, they just fade away. And that was my plan. However, there was a huge uproar over this article. And I think for a couple of reasons. One is because the word pronoun was in the title, so that elicited a response, and we can get into that a little bit about where that has all gone in medicine. And then it was the fact that my school decided to issue a denunciation of this. And they said that the school stood for diversity, equity, and inclusion. There was nothing at all about diversity in the substance of the article. And it was, as I said, simply about my sense that the curriculum was going off the rails and that it needed to really focus on science and not on social issues. There was such an uproar over this that the Wall Street Journal then wrote an editorial 2 days later saying, well, I guess Goldfarb was right, because this response is so disproportionate to the substance of what he wrote, that clearly there's something going on here in American medical education. Well, after that, the pandemic hit. And as you all know, this has been one of the great disruptors of American life. And I think we'll be looking back on this for many years, understanding what it's done to us and what it's done to medicine. And I feel terrible. When I think back on how my colleagues had to deal with this, I fortunately or unfortunately was really spared having to be directly involved in patient care at that point. I was at the point of retiring anyhow. But it struck me that, you know, I really need to get more of my ideas out at that time. And I was about to take a sabbatical, and I decided to write a book. And the book came out, and the AAPS was nice enough to actually review my book. I got the journal where it was reviewed, and I appreciated that. And the book was really kind of a cri de coeur of someone who just felt like medicine, and particularly medical education, that really was my focus, was really going off the rails and really needed to be refocused on improving the quality of education, improving the quality of applicants that were entering medical education, medical schools, and improving the whole approach to developing a future physician healthcare enterprise in the United States. And the book, gave all these ideas, and it sort of merged two ideas, the ideas that woke issues in medicine were creating a real problem. And even before we came on the air, Richard enunciated some of these issues, because what was happening in medicine clearly was this idea that we needed to discriminate the way we treated patients. And that certainly blew up after George Floyd was killed, when we had students and faculty members across the country at medical schools putting on their white coats and raising their right fists and saying that white coats for Black lives was the way we had to generate this new paradigm in medical education. That was the symbol of it, and that we had to develop this whole huge enterprise in diversity, equity, and inclusion in medical education. So it seemed to me that at that point that it wasn't just enough to talk about it. Everybody was starting to talk about it at that point, but really no one was really doing much about it. I was very fortunate to have the opportunity to work with some people that had been quite successful in putting together groups to combat critical race theory in K through 12 education. This was a particular group called Parents Defending Education, and they've been very successful with two kinds of models. One is to inform the public, which obviously the public now and parents have become very well informed about critical race theory in K through 12 and what it's done to the education and the mentoring of their children. And then they were effective in also thinking about legislative and even legal approaches. So Do No Harm was formed in order to actually piggyback on this kind of approach in medical education and in healthcare. So the organization really has had three kinds of foci. One is to inform the public. And we've been able to do this, I think, fairly successfully, mostly because we've had some very wonderful donors that have supported us. And it's very expensive to get the word out. We have public relation firms and digital firm and again, donors that have been extraordinarily generous to us so that we've been able to get our word out there. And right now, our organization has over 5,000 members who are physicians, nurses, patients, medical students as well. And it's a 501c3, which means it's a not-for-profit. It has limited capacity to do lobbying and other influencing of elections, for example. But we can do some of that. And in fact, we have done some of that. And the other things that we've done, which also, I must say, is a very expensive enterprise, but one we've been able to carry out now, is to influence legislation. So above and beyond getting the word out through multiple op-eds in the Wall Street Journal, Washington Post. We mentioned a little bit earlier that Marilyn Singleton wrote a lovely op-ed for us in the Washington Post, one of your former presidents, talking about the fact that as a Black woman and physician, that she was really offended by the idea that discriminatory practices were introduced into medicine. The second approach that we've taken has been in the legislative arena. And in the legislative arena, we've been out there at the state level. It turns out that's, of course, where a lot of medical, the supervision of medical practice and medical education occurs. I've testified now in 3 states to legislative bodies about laws that we've helped craft. The legislators write the laws, but we've given them some of the ideas through our lobbying efforts. And in Kentucky, and in Tennessee, Kansas, and in Missouri, I've testified before the legislatures and talked to various influential members of those legislative bodies about getting laws passed. And I think we've been doing pretty well there. And lastly, we decided to pursue the issue of legal remedies. And we have 3 lawsuits that we're involved in right now. One lawsuit is against the federal government, and we've just received a positive ruling from a federal judge about this. So I'll tell you about this lawsuit. It goes back to 2021 when in Medicare, a rule was published that physicians would be able to get incremental payments in the quality improvement program in Medicare if they had an anti-racism protocol in their practice. And as most of you probably know, anti-racism doesn't mean what it says. Anti-racism is actually racist. Anti-racism means that you have to create a discriminatory activity that favors one group of patients over another in order to redress old, unfair, discriminatory practices that occurred in some cases hundreds of years ago. And the Medicare rule was that if you put such an anti-racism protocol in your practice, you can get this incremental payment. Well, we're a membership organization. Our member was able to be the plaintiff, and it was joined by 8 attorneys general of various states who have now been part of this lawsuit. And as I said, the judge recently issued a ruling just the other day that our member did not have standing, but the judge felt that the attorneys general did have standing, and this case is going forward. And we basically were told we were going to win this case, and that Medicare was not going to be able to implement this anti-racism protocol. The other kinds of legal approaches we've taken has been to write to offices of civil rights, the Office of Civil Rights, about various scholarship programs that are present in various hospitals that are trying to attract minority students to their hospitals for filling up their residency programs. And we'll talk a moment about the diversity part of things. And the point was almost all of these scholarship programs that were put out there would have a statement that whites and Asian students need not apply. This was purely for Black and for Latino students. And this is illegal. This goes against the civil rights laws of this country. If any institution takes government money, they cannot have such programs. And we've launched over 100 of these kinds of letters now. And we even had an interesting discussion with the chief counsel of the University of Florida, who called up as soon as we wrote a letter, and the Office of Civil Rights contacted them saying, okay, what can we do to make this go away? And understanding that these kinds of programs are illegal. And then we've sued 2 other organizations. One is, that you may have heard of, is called Pfizer. Pfizer has had a program which was a very rich program for bringing minority candidates into their organization, giving them master's degrees, the support for a master's degree, very excellent employment opportunities and mentoring opportunities. Again, whites and Asians need not apply. Well, we had a member who felt like he would apply if he were able to, and that lawsuit is going on. Pfizer decided to hire Loretta Lynch, the former Attorney General of the United States to fight against us. And that's working its way through the federal court system as well. And finally, we sued a medical publication, Health Affairs, and we're all probably familiar with it. It's kind of considers itself the Bible of health policy journals. And we sued them because they too had a program that simply was exclusionary of whites and Asians. Only Black and Latinos individuals need apply, and it would be a chance for medical students or young investigators to see how a medical journal works and participate in the medical journals through a fellowship program. So, that represents sort of the scope of the kinds of activities that Do No Harm is involved in now. As I said, we have over 5,000 members that are sending us tips and information virtually every day. It's almost overwhelming how much information we've gotten. And some of these have been quite extraordinary. And they've spoken to the overwhelming interest that medical institutions, particularly large health systems and the medical schools themselves, have decided to go down this path of the so-called diversity, equity, inclusion. I don't like to use DEI. This is woke, this is woke, and they don't like to hear the word woke because they feel it's demeaning, but it needs to be demeaning because it's a horrible concept. The words are exactly opposite of what DEI really speaks to. It's not diversity that they want. It's a very narrow idea of having more minority individuals with an ultimate goal of having the same number of Black students in medical school as there are Blacks in the population at large. It really is a quota system. And equity doesn't mean, of course, that everybody will be treated equally. It means, in fact, just the opposite. It means that certain groups will be favored in order to achieve outcomes in which all outcomes are equal, and requires favoritism to accomplish that. And inclusion really is exclusionary. It includes only certain groups of individuals. So the words have been Orwellianly, if that's a word, changed in order to accomplish this kind of ideological approach that has been required. And our organization, when people ask me, well, what are you really for? What we're for is the absence of all discriminatory activities in medicine. We want a colorblind approach to medical education, colorblind approach to medical care, and a colorblind approach to the ranks of the faculty and other individuals in medical education. And we recently saw we got a tip from one of our members that actually was written up by Fox News Digital just the day before yesterday. And this was from Indiana University. They have a combined campus with Purdue. And this was a presentation that was given to faculty search committees of how they should hire individuals on the faculty of that institution. And the one that was just extraordinary was comparing equity of merit versus equity of wokeness, equity of diversity. And the merit example was to think about hiring an individual who had worked perhaps in a Nobel Prize winning laboratory, had been at elite institutions, had been mentored by important individuals in medical science. That was not the way that you should base a hire at that medical school. The way you should base a hire is someone that could relate to the students, relate to minority groups, relate to other cultures. And this was viewed as more important than the merit and the academic achievements of the individual that they were hired. Now, if anything describes an approach that's going to destroy the medical system in the United States, it's an approach in which merit, in which individual achievement is downgraded to serve this idea that diversity is really the key to having a successful medical system. Now, I've looked very carefully at the literature that has been used to justify this approach to diversity. In fact, the literature does not support the idea that Black patients should have Black physicians. Now, I've worked with some fantastic Black physicians who are absolutely brilliant, and I'd be absolutely delighted to have them care for me if I should need that particular kind of care that they can provide. That's not the point. The point is that we should not start taking individuals into medical school who are less qualified simply in order to achieve this idea of numbers. And my old school, the University of Pennsylvania, has started a recent program that they are trying to recruit and will be recruiting 10 students a year from historically Black colleges and universities. All the students need to do is to have had something like a 1300 SAT score, and then maintain a 3.2 average in medical school. They don't have to take the MCATs. They don't have to show their ability on that exam, and they will be mentored, and then they will be supported through medical school. Now, the reason that they need to do this is because there just aren't enough qualified minority applicants. There just aren't. And I would challenge any medical school to show me that they've ever turned down a qualified minority applicant, because they haven't. But rather, this is the idea of trying to take individuals who may or may not be capable of being good physicians. Maybe they are, maybe they aren't, and supporting them through their medical education in order to achieve this outcome of having an increased number of Black students and Latino students, particularly Black students, and particularly Black men who enter into medical education. There are plenty of brilliant Black men out there. They don't want to go to medical school, and bringing in Black men who aren't as brilliant to achieve this quota system, really, I think is just a terrible error. And you should know that back when I graduated from medical school, which is going back into the 60s now, the attrition rate in medical school was something like 9% nationally. Some schools were as high as 15%. That probably wasn't wonderful if you were one of those students. You know, it's the old story of look to your left, look to your right, one of you isn't going to be here. But that wasn't perfect. On the other hand, medical school was quite difficult, and you were expected to perform. These days, the graduation rate for medical school is over 97%. So there's a large cohort of physicians who are graduating from medical school now simply on the basis of, I think, being showing competency without showing excellence, and being shepherded through. Over 40 medical schools in the United States now have coaching programs where students are linked up with faculty members to give them extra work so that they can pass these exams. And as I tried to write in my book, the way, and I was, of course, completely familiar with this, the way that exams are now given in medical school is the students are basically told what's going to be on the exam and then asked to hit something like a 65% success rate in order to pass the course. And even then, there are students that are taking the exams 2 or 3 times. And I recently ran across the woman who runs the genetics course at Penn and who told me a story like this. They had a student, 4 students who failed the retake exam, and they're going to be passed through. They're going to take the exam a 3rd time. So to sort of conclude with my rant about the way I see medical education going in the United States, I'm very concerned about the fact that we've lowered the standards dramatically to serve this idea of diversity, an idea that could ultimately lead to a situation that I think all of us should really think is a terrible outcome. And that outcome would be patients coming to the hospital and asking for a physician of a particular race to be their doctor. Now, I've been at Penn when patients came in and said, I don't want a Black person to come into my room. And our response to them was, you probably should go to another hospital because we're not going to put up with such nonsense. And the same way, I don't want to have a country in which that goes on. I don't want to have a country in which Black patients come in and demand Black doctors. I don't want a country in which white patients come in and demand white doctors. I want a country where the merit rules, who has the great privilege of being part of our profession, rather than any other sort of criterion. And I think the death of meritocracy in medical education and in medicine in general is just a terrible development that will only lead to us looking back years from now and saying, you know, what have we done? What have we done to our profession? So let me stop at this point, because I've spoken a little bit longer than we even planned, because I really would love to have a discussion with the members of the AAPS and see what questions you have and whether or not we can have a dialogue about some of these issues. So thank you.
Great. Dan, that was wonderful. Before we open it up to questions from the audience, I had a couple of comments, questions that we perhaps we could discuss as well, touching on things that you mentioned. This idea of the dumbing down of medicine is quite horrifying. I witnessed it up close and personal during my 5 years at St. George's University down in Grenada. There is simply not enough time for these students to get any kind of even a rudimentary level of understanding of the basic sciences, which are, of course, the backbone of medicine. If you don't understand these things, you're not going to be able to do much more than click on boxes in your electronic health record and hit the prescribe button and give out pharmaceutical products, which is, of course, what I think is really one of the agendas behind this dumbing down. They don't really want scientific, creative thinking doctors anymore, and they won't get them. And that is a tragedy for medicine. Medicine truly did have an excellent standard. And if that goes away, I wonder if it will ever come back. Your thoughts?
No, I think that's exactly right. You know, the one of the quotes that woman who became the head of medical education at Penn said to me one day, she said, "There's too much science in the curriculum." Just think about that. All of you physicians out there, there's too much science in the curriculum. We need to teach them to be advocates. That's what we need to teach them to be. The goal is to have students march down the street with their white coats on, advocating for electric cars, whatever sort of political goal you're particularly interested in these days. That seems to be the goal. And you know, to a great extent, it's working. I think one of the things we saw was that, and this was sort of an interesting little issue for Do No Harm. And by the way, I should just tell you, just to advertise our website, it's donoharmmedicine.org, which is Do No Harm Medicine is one word, and we have lots of opportunities on there to join. We're not interested in raising money. We're interested in having members, and we're interested in having you sort of have the information that we've been able to get. So anyway, what we did was we noticed through our FOIA activities, that's the Freedom of Information Act request that we've been able to put in to public medical schools, that there was a program going on by the AAMC where they were giving a scorecard, a dashboard to medical schools to see how woke they had become, which is really what it was. How much they had invested in the diversity issues, how many faculty they had recruited, how many faculty they have who have to write diversity statements in order to get promoted, how many people on their staff they have in their diversity, equity, and inclusion offices. The AAMC, the Association of American Medical Colleges, planned to send out this generic national report card to just show where they were. But by FOIAing that created verb, the information, we found out from individual schools. And we found out some schools, for example, Indiana University was something up in the, I think there's, I may be misquoting the exact number, but they were up at 80%. There were schools that were at 70% and were told, you've got to do better by the AAMC. And they were quite upset that they weren't at 100% of the diversity scorecard. So this is what's much more important in medical education. It's more important to have somebody who looks a certain way than to have someone who's going to be the creative thinker, the Peter McCulloughs of the world, who look at the problems and say, I see them in a very different light and I have very different feelings, and people need to listen and study their ideas and decide whether their ideas are correct or not. You know, this is really a rejection of the Enlightenment. It's a rejection of logic and reason and replacing it with emotion. How you feel about your physician, how you feel about your school, how you feel about things is much more important than what you know. And I think all of us, when push comes to shove, what we really want in our physicians is we want someone who knows how to make us better when we're ill, how to relieve our suffering. Certainly, we need to communicate well with our patients. No one denies that. We need to be affable, we need to be available, but most of all, you need to be knowledgeable. And the idea that there's too much science in the curriculum is absurdity. And the other thing that this woman said to me was, if they don't know some of the science, they can look it up. And, you know, so that's what we're creating here. And and there has to be a stop to this.
The other thing, you know, one of the things that Marilyn Singleton pointed out in her great op-ed was this horrific notion that doctors are somehow racist in their approach to patients. And she was just horrified by this thought. And she was so right. I mean, doctors understand better than any other profession that we are all the same under the skin. We are the least racist group out there. Plus, our ethic is to treat patients as individuals, is not to treat them as a group, to treat them as an individual. So this notion that physicians are somehow racist and that's why health outcomes are so bad in minority populations is a total absurdity and must be rejected entirely. Your thoughts?
Yes, and, you know, and I've been very interested in this question of what's the basis for healthcare disparities. Inevitably, it's about not getting enough healthcare, not getting healthcare at the right time, much more than anything else. You know, amputations are so prevalent in the Black community. And if you I talked to the person who was the president of the Vascular Society of America, said they absolutely come in too late. And that's why we can't salvage limbs at that point. And that's the problem. These are cultural issues. This is a question of trust. And the more that institutions like Penn and like Yale and these, you know, famous academic medical centers declare themselves to be racist and the need to expunge racism, the less that the people that really need to trust those institutions are really going to be able to trust them. Because, I mean, really, would you go to a place that tells you we've been very racist and we're going to try to get rid of it now, but, you know, we're working on it? Is that an institution that, you know, a minority individual, minority citizen would look at and say, yeah, that's a place I ought to go to get care? And I think the lack of acceptance of some of the COVID vaccines, for example, early on, it clearly was just, they just didn't trust the situation. Maybe they were right, but nonetheless, the issue was, you know, a lack of trust in the healthcare system. And this whole approach to decide that we need racial concordance between doctors and patients, which is a particular, you know, concern that I have, I think is one that's just going to lead to a really terrible situation in American medicine. You know,
yeah, go ahead.
Let me say the other issue that our organization, Do No Harm, has taken on, which I'd like to just talk about for a moment, if I can, is the issue of the so-called gender affirming care.
Just what I was going to ask you about.
Yeah, so we decided after thinking hard about this, because most of our efforts, and our organization has been only in existence for a year now. We're celebrating our year anniversary. But after about 3 or 4 months of working on the issues of woke medicine, it became clear that in good conscience, we needed to speak out about the issue of this gender affirming care in children. And this is not about adults. You know, adults can do what they want. If physicians are working with adults, okay, that's really their business. We're focusing completely on children. And we've developed a fairly aggressive program, again, using legislative issues. And we've been involved in several states in the Midwest and in Florida and Alabama and other places which have passed laws about this. And because it's quite clear that the science behind transitioning children is not, it doesn't support what's going on. And it's quite interesting that 3 European countries now, Finland, Norway, and the United Kingdom, have all put huge barriers in the way of putting children through these various kinds of treatments, both social transitioning, even certainly the puberty blockers, and then sex altering hormones. And, you know, in the United States, it really is scandalous what's gone on in some institutions. I don't know that all of them behave this way. I don't know, but this recent report from Washington University in St. Louis, the Children's Hospital there, Jamie Reed, the woman who worked there, a trans woman whose partner is transgender, and she just said, I could not in good conscience continue with this. And she signed an affidavit saying that, you know, children were really being mistreated at that institution. And, you know, if she's lying, she can go to jail. So this is a very serious issue. And this seems to be what's going on in the United States. So we've taken this issue on as well. And again, I think that we're working very hard. Now, I'm no expert in this area. We have a number of physicians now who are pediatricians, psychiatrists, Miriam Grossman, who you may or may not know of, but she's been a psychiatrist, has been very active in this space, and she's one of our senior fellows now. And we have pediatric endocrinologists and pediatricians who are specialists in child abuse issues, because we think a lot of this falls under that area. So I don't go around testifying about this, but I'm willing to speak out as a physician, as a concerned citizen, because I think this is an approach that's been taken in the United States that I think is quite dreadful.
Yeah, we completely agree with you. AAPS, in fact, just released a statement condemning this practice of gender affirming care in minors, both the hormonal treatment, the rapid endorsement of their so-called choice at age 8, 9, 10, 11, whatever, to go that route without any kind of real counseling. It is horrific. It is, I think, completely unscientific, completely unethical. And this is sadly being taught in medical school, this gender insanity. It's great that you have Miriam Grossman on with you, because her interview with Jan at Epic TV was brilliant. And she said in that interview that the entire scientific basis for gender fluidity and gender, dysphoria in a way, and gender transitioning was based on a fraudulent study by a psychiatrist from Johns Hopkins, this guy, John Money, who had two boys who were, one was raised as a girl, one as a boy. And he claimed that this was no problem, when in fact, the child who was raised as a girl never accepted being a girl. In spite of being dressed like one and being told to act like one, he remained a boy. And this guy Money lied about his study and abused the two boys, apparently. And this is the entire basis.
Yeah, no, it's terrible. Terrible story. Yeah, and you know, just to sort of kind of tie it to the issues of diversity and equity is, I think in each case, what's happening is we're using identity of a group as a substitute for the individual characteristics of a patient. You go in a room and there's a Black individual there. That's an individual with her or his problems. They're not part of a group. It's not a Black patient. It's Mrs. Jones or Mr. Jones who has a problem and they need our individual attention. And it's the same, and they're urging us to treat them differently because of their skin color and because of history. And the same with these kids. They're telling us these are trans kids. These kids know that they're trans, and therefore we have to affirm that and we have to support that. And we have the highest levels of the United States government supporting this in ways that are absolutely outrageous. And in each case, it's this idea of the group identity having much more to do with how we should interact with patients than it is as individual human beings that we need to worry about. Let me just say, we received, again, a tip, so that I'm urging your members to join us as well, so we can have more of this information coming in. We had a tip from Indiana University School of Medicine, which is incredibly woke. Probably the most woke one is University of North Carolina, but that's for another discussion. But and this was a course on reproductive anatomy. And in the course on reproductive anatomy, the whole question of gender was discussed in this presentation about reproductive anatomy, using these extraordinarily rare cases of intersex individuals, various adrenal steroid unresponsiveness or hyperresponsiveness syndromes that are, incredibly uncommon, but, are seen by pediatric endocrinologists on occasion as evidence that there is no such a thing as two genders. There's a spectrum of gender. And it was just outrageous. It was so bad that the senator from Indiana just wrote to the medical school asking them to explain exactly what it is they're teaching these medical students and how, why ideology has taken over the medical curriculum there.
Yeah, I mean, it's a complete denial of scientific reality that gender is determined by your biological sex, which is determined by your chromosomal makeup. And this is a tactic of the left, which is to categorize people as members of a group, as opposed to an individual. And this is what we must push back against. Everyone is an individual. We are not just a member of a group, and we have to completely rebel against that concept. But Jeremy, I think it's time to, open it up to the wider
please.
audience.
Great. Yeah, thank you. Wonderful discussion. Thank you both. And we do have some attendees with their hands up. If you do want to ask your question verbally, go ahead and click the raise your hand button and we'll get to you. Otherwise, type it in the Q&A box and we'll try to field all those questions as well. It looks like we have a few hands raised, and one of them is Dr. Harvey Reish. Dr. Reish, it's an honor to have you here. I'm going to click the button to bring you on, and then please proceed with your question. Dr. Reish.
Okay.
Hi, welcome.
I loved the discussion. When my son, who's now third year med school, was applying to med schools, I had a discussion with Bob Alpern, who was the dean of Yale Medical School, about acceptance quotas by race. And I had pre-researched that Yale and other medical schools had racial ethnic quotas. In 1951, I had a publication showing that. And the AAMC at that time said exactly the same words that you used, which is that we want doctors to look representationally like the general public. And I was astonished in talking to Alpern. He said exactly the same words, literally the same phrase, coming from the AAMC 5 years ago, or 3 years ago, whatever it was, that was in 1951. This has been a much longer problem. And for example, the Stanford University, which has had a classical period of anti-Semitic inequality in its acceptances to the university, that like many of the Ivies over the 1930s to 1950s into the 60s, Jean-Luc Tissier, the president, apologized for that. At the same time, he had quotas in the medical school acceptance. He's apologizing for past bigotry and acceptance while he still had quotas in the medical school. I think we have a much bigger fish to fry here, and that's the AAMC and the people who have been wokenized there or continuing its wokedom.
Yeah, I was telling the moderator just before that I was in Washington this afternoon speaking to the staff members of the House Oversight Committee. Congress is getting very concerned about this, and they see this as an important issue. Everybody says we shouldn't be engaging in culture wars. I think just the opposite. I think the culture wars are the most important wars that we can engage in right now. It really is the future of the country we're talking about here, what kind of nation we're going to have, and whether it's going to be a country that, our parents would recognize, or one that will just be completely something so different from what I grew up with, and what I think, has been an ennobling American idea of having a melting pot and having individual opportunity, having people being able to rise up. And I'm afraid that we're going in a direction that's not going to allow that to be the case in the future.
Thank you, Professor Reish, for that, bringing up that point, and for Dr. Goldfarb for the discussion. Right, we have some additional hands up. Before we go to the next hand, which will be Dr. Wheeler. So just get ready, Dr. Wheeler. There's a question here in the Q&A box, and this is something that I've recently learned about too. This doctor says, many states are requiring implicit bias training or DEI education as a requirement to get or retain a license. Like I know Michigan is one example. I don't know if there are other states. I know Michigan's doing that. Maybe there are other states too. And AAPS has been looking at how to challenge that. And one way is politically. I mean, you need to get new political leaders in, and maybe in Michigan that is still possible. But I don't know what your reaction to that is, Dr. Goldfarb. Have you looked at some of the state licensing laws?
It's Massachusetts as well. And we've had members who have written in that they refused to take this training. And you know, it's a very interesting story, because the scientific basis, quote, scientific, unquote, basis for this is something called the implicit association test, which is a test that everyone can take. It's online. It was developed at Harvard in the late 1990s. And it is a test that's been taken by physicians as part of clinical studies, as part of mostly sort of social science studies, to show that physicians are biased against Black people. Now, this implicit association test, I'll just describe it for you. Pictures appear on your computer screen when you sign up for this, and then a word appears, like a picture of a Black person may appear, and then the word good may appear. And then the picture of a white person and the word good will appear. How quickly you press a button in recognition of your agreement or disagreement with the descriptor and the picture determines whether you're biased or not. So if you take longer to press the good button for a Black person compared to a white person, you're biased against Black people. Well, two things about this. First of all, the test is not reproducible. So if people take the tests on two separate occasions, the results do not match. There's like a 50% variance. So the test has been completely debunked. The other thing that's been found is that people, when they take the test, they kind of know what the test is about. And if there is even evidence that this, what's interpreted as bias against Black people, is actually bias for Black people. They feel like Black people have been not treated well, and they react differently to the pictures compared to the way they do white people. So this is a totally useless test. And yet when you read the literature about the need to get rid of implicit biases, it's based on the results of this test that's been done in multiple fields. And I would just say this about it. I don't deny that people have biases. The issue for us as professionals is, how do we treat our patients? Not what's deep in the recesses of our mind, but when Mrs. Jones comes in and needs to get put on an SGLT2 blocker for her diabetes, do we put her on this, or decide, no, I'm not going to give her a medication that I know is particularly beneficial these days because of her skin color? And this is absurd on the surface of it. And you see papers. One paper recently claimed that neurosurgeons refuse to operate on Black people who have brain tumors. And I read this paper and I said, you know, I know a lot of neurosurgeons. I don't know a neurosurgeon that would ever turn down the opportunity to treat a patient with a brain tumor and treat them surgically if that was the right thing for that patient to have. And yet this paper claimed that patients were being denied surgery. And that was the explanation, that these are people who are demonstrating their implicit bias against Black patients. Just question studies that are absurd on the surface. So this idea that that we should be training individuals about implicit biases is just a terrible idea. It's been shown that these kinds of courses, in fact, engender more hostility on the part of individuals because they feel so angry about this. And one of our members, Dr. Rick Bossert, who's been quite visible in the last few months or so, he was on Tucker Carlson's show, for example. He was a fellow of the American College of Surgery. And he was the American College of Surgery, and most of the medical organizations, are incredibly aggressive about developing these kinds of woke kinds of requirements. And he spoke out against it because he felt that merit was the most important thing. And he was against the fact that the organizations were recommending implicit bias training and so on for the fellows. And he was prevented from participating in the chat room of the American College of Surgery, even though he's a fellow of that organization, because of these sorts of ideas and his opposition to this kind of nonsense. So it's a terrible idea, and it suggests that, you know, we're being driven by these unconscious issues that prevent us from acting in a professional and responsible manner. And I think the membership of your organization knows that this is just ridiculous.
Thank you, Dr. Goldfarb. All right, Dr. Wheeler, it looks like lowered his hand, so we're not going to go to him. Dr. Wheeler, if that was a mistake, just raise your hand again. But we will go to Dr. Ken Fisher, who has his hand raised. Dr. Fisher, I'm clicking the button to allow you on here, and please proceed with your question. Thanks for joining us.
Sure, it's a pleasure. Thank you very much, Dr. Goldfarb. I am a member of your group, but isn't the question of the lack of Hispanic and Black qualified people an issue of poor K through 12 education? Isn't the answer to better educate minority groups than it is to make special considerations? Yet nobody talks about this. The Supreme Court finding about, yes, we should have racial biases, never considered that fact. And the question is, why do we allow poor education in our inner cities? Thank you.
Yeah, well, thank you, Dr. Fisher. Let me tell you a little bit of an anecdote because you've made the point why no one talks about this. So the anecdote was that I wrote a tweet, and I recommend against doing this, writing tweets, but I wrote a tweet in response to a paper that I read that was in Academic Medicine, which, as you know, is the journal of the Association of American Medical Colleges, our beloved AAMC. And this paper, which came out it's about 6 months ago now, was the result of a study that was done at 3 prestigious institutions, MGH, Brigham, University of Virginia, and Emory, where they aggregated the assessment of minority residents compared to non-minority residents by the faculty of those institutions. And these were internal medicine residency programs. And the bottom line of the study was that they found that in every category, the average results for the minority residents were less good than the non-minority residents in both professionalism, readiness to practice, medical knowledge. Now, no doubt within that minority group, there were some that were terrific, and there were some that really were probably terrible. And that's why the average was low. So this was about individuals within the group and not about their group characteristics. Nonetheless, the authors of the paper wrote that there were 3 explanations for this. One was that the assessors, the faculty, were racist. 2, that the institutional assessment system was racist. Or 3, that the institutions were not inclusive enough and did not provide support enough for these trainees. The tweet that I wrote was, well, here I referenced the paper and gave the link, and I said, they gave 3 explanations. Could it be that they weren't so good at being residents? Now, it seemed to me that that was an obvious possibility. It might not have been the right possibility, but the fact that they didn't even raise the possibility that this group did not perform as well seemed to me to be absurd and just illogical not to raise it. So I wrote that tweet. The next thing that happened was my former chairman, who's a friend of mine, and I'm still friendly with him. He had to write up an email to the Department of Medicine at Penn that my racist comments were something that he totally was embarrassed about and angry about, and and launched this out. And then there was a huge Twitter uprising against Penn, to the point where they took my name off the website, even though I'm an emeritus professor there. You can't find my name on the website. And to make matters even worse, they took my name out of the history of the Penn Renal Division, where I was the co-director there. Just expunged my name from the history of the Renal Division, which is on the Renal Division's website. Now, I only raise this to point out that you can't even say things that are, I think, anodyne at worst, without falling into this abyss of cancellation. So I urge you all to be careful, because even, speaking about this in the most modest terms, and, my basic view is, I just feel like I'm going to say what's on my mind. And I believe, in my heart of hearts that the next Black person I meet is a Black person that is going to be an individual, and I'm going to treat them like everybody else. And the next Black doctor that I see, I'm going to assume they're a good doctor, and let's see what happens. And I don't feel like any of my comments that I've said tonight or that I've written have in any way can be interpreted as being racist, unless you define racism as anything that does not consider that the only way that white people interact with Black people is to oppress them, which is basically the substance of critical race theory. That really is what it's all revolves around, the idea that white people are oppressing Black people, and that's the only kind of interaction that they have. So yeah, I mean, it would be wonderful if we could change the educational system, but that's a tough one, because it's all about how you're treated at home. My wife taught in the Philadelphia public school system in the most impoverished areas for 45 years, and it's all about treating them as individuals. Some of the kids were terrific and rose above their circumstances, and some of the kids just were not interested in rising at all. And it's about culture, it's about home life, and it's about people having ambition and people wishing to rise above their circumstances. As many of you as I did, and as many of you, I'm sure, in the audience did. And that's hard for any kind of an educational system to accomplish.
And my colleague, Dr. Reish, raises an excellent point, which is that this does go way back. And of course, it goes way back to the dawn of the affirmative action era, which is 70s. And it's gotten worse and worse and worse, to the point where, as Heather McDonald pointed out in her recent article, the average MCAT score for an accepted white or Asian student is about 71 percentile, whereas the average MCAT score for a minority accepted applicant is about 35th percentile. It's a huge, huge disparity. And the MCAT, sadly, is one of the only criteria we have to be able to judge how well someone is going to perform in medical school. We looked at, when I was at SGU, I was on the admissions committee, we looked at the GPA and sought to see if that was any sort of a predictor. It turns out not to be at all. There is no correlation between GPA and success in first 2 years of medical school. And that is due to this phenomenon of grade inflation. The GPA has become pretty much meaningless. All we have left are these objective exams like the MCAT. And of course, the woke crowd want to get rid of the MCAT. They've already dumbed down the USMLE Part 1 to pass-fail. And that was another very big hurdle to get through to get into a residency program. So the trend is not good, as they say.
Yeah, in my book, and I don't want to push my book, but I spent a fair amount of time on this issue of the grades, of the grading system and the exams and the rationale. The MCAT was put in place in the 1930s because of such a high attrition rate. In those days, it was even higher than the 9% or so that I mentioned before. It was put in to make sure that the students that were being accepted into medical school would be able to do the work. And now it's being abandoned. And basically, 25% of it now is these social issues, again, to demonstrate whether someone is more interested in social issues than they are in science, as a big criterion for entry into medical school. Another study that we did through a FOIA effort was to look at the application processes in various medical schools. And what we found was virtually 80% of medical schools that we surveyed, that we were able to get information from, they have two parts of the application process. Dr. Reich might be able to speak to this because of his son who's in medical school. The first part is the standard demographic sort of question about their activities, academics, and so on. The second question is, what do you do to support diverse issues? What do you do to support diversity? So they're picking out the students in the beginning who are going to have this attitude that it isn't important how hard I work. What's important is, how much I'm going to adopt this woke kind of approach. And we had one student who wrote to us and said, we have woke Wednesdays at our school. And that's the day that we spend the whole day going on, talking about these issues. And, it's, I just think that it's time to push back, time to push back against it.
Yeah. Great discussion. Thank you. And I'll push your book. It's full of very important facts and figures, and it's easy to read, compelling read. So if you don't have a copy of it, make sure you get it. Take 2 aspirin and call me by my pronouns. You can get it at Amazon for Kindle. That's how I got it. And there are a number of really good questions in the Q&A box, and we're going to try to get to as many as possible, but end on time in about 20 minutes. But we'll take a quick break and introduce Dr. Elizabeth Smoots, who has some information to share. And Dr. Smoots did a lot of behind the scenes work to organize our event tonight, as well as our January webinar on Marxism in medicine. We're grateful to her for her efforts and help. And I'm going to share her slides right now. And then Dr. Smoots, please go ahead. I'll put your slides on here right now.
Thanks, Jeremy.
Okay, thank you. And just let me know when you want the next slide.
All right, thanks. I'd like to thank Dr. Goldfarb for his invaluable insights into the woke takeover of medicine, and hopefully we'll have a chance to get around to hearing what we can do to help. I'd like to announce that we do have a couple of handouts for everyone tonight. The handout number 1 is called Data Designed to Deceive: The Corruption of Medical Research with Ideology. And this is a handout that is fresh off the press today. It describes how today's research corruption is similar to what happened in the Soviet Union. Lysenko was a Soviet scientist in the 1930s who claimed that exposing wheat seeds to moisture and cold could create future generations of wheat that could withstand harsh weather. He was wrong. And those who opposed his methods were executed or sent to forced labor camps. When the communist elites prioritized politics over science, the result was massive famine and the starvation deaths of tens of millions of people. So as handout number 1 explains, the current medical research corruption that we have today is the medical Lysenkoism of our time. We'll post a link to this handout in the chat, and we'll also send it out by email in the near future. The next handout, turn the slide to handout number 2. This is a resource from Do No Harm that I think might be valuable to many health professionals, and it's titled Forced to Take Implicit Bias Training. Here's how to respond. And as you've heard, Do No Harm has a number of additional resources on their website that I encourage you to take a look at. We'll include the link for this handout in the post-webinar email as well. And then finally, next slide, please. We have a list of additional resources for those of you who are wondering about the ideology that's behind the woke takeover of medicine. And I highly recommend viewing the Marxism in Medicine webinar, which AAPS produced in January. And we've got a link to that slide right there. And then also, I write the 2026 Substack, where you'll find additional articles pertinent to tonight's discussion. I'd like to point to you to 3 in particular. We have the top 7 Marxism clues, also Marxism in current events. And those 2 articles we both used as handouts for the recent Marxism in Medicine webinar. And then also there's an article called Legacy of Lies. And that article is about how we got where we are today. and why it matters. And it turns out that in the 1990s, at the end of the Cold War, archives were released from the Soviet Union and from the United States and made available to the public. And even so, in the United States today, the media still conceals this information. History books censor it, and the public doesn't know about it. And this article summarizes the situation and provides references for greater detail. So I'd like to end with the conclusion from The Legacy of Lies: let our future decisions be based on facts instead of lies. Thank you. And I'd like to turn the program back over to Jeremy for the more questions. I would like to hear from Dr. Goldfarb what we can do to help.
Thank you, Dr. Smuts, for that helpful information. And yep, we will provide those links in the post-event email, and I'll also be putting them in the chat here shortly. But going back to the Q&A, and let's see, we do have another hand raised. Let's see who has their hand up. Dr. Nobel, Dr. Abigail Nobel, welcome to the webinar. Please proceed with your question.
Thank you. I'm actually a nurse with an MA in politics. I run Michigan Healthcare Freedom, teaching people about health policy in Michigan. And so the references to implicit bias training really caught my ear. In our state, it really seems that the only way out is going to be through a lawsuit from a licensed professional, because it's required 1 CEU or CE per year for all human health professionals in Michigan. The veterinarians managed to escape. Not sure how, but they did. And so I'm just wondering, is there any progress toward a lawsuit anywhere in the US? And just as a side note, my Hillsdale 10-year grad school celebration was last week, and I heard the words counter-revolutionary and reconstruction as the two main characteristics of statesmanship for America's future. So be encouraged. I'm hearing lots of good things from you.
Yeah, that's great. Yeah, and that's a wonderful institution. You know, the laws that we've been, the legislation that we've been advocating has specifically addressed this issue of demanding. I'll tell you, the legislation specifically that is being run through several states, particularly in the Midwest and the South, mostly states that have legislatures that are likely to pass it. I mean, we haven't gone to New York or California. It's just a waste of time to even try there. But in the states like Tennessee and Missouri and Kansas and perhaps Texas, the laws, the DEI law that we've been advocating for had really 4 components. One is making sure that the public knows the criterion for entry into medical school, so that can be discussed openly. 2 is that physicians need not in medical school sign any of these DEI pledges that has become part of the promotion and reappointment process. And a bunch of schools have now said, I think 3 schools that I can identify, University of Houston, Texas A&M, and University of North Carolina, have all said that they'll eliminate these. And I think University of Missouri also, where interestingly, we testified down there about this, have eliminated this requirement for faculty to get promoted. We've also argued for no required DEI training in the licensure process. And finally, we've asked for no expenditure of state funds on various consultants that come in to give these $60,000 to $100,000 one-day seminars on DEI training for the staffs and faculty of institutions. It may sound like it's, you know, too focused and it isn't going to have the effect, but I can tell you that the legislators, they need to have laws, and they need to have the basis for passing laws that they think can pass. That there's a spectrum of political ideology in all of these states, and they need to be able to get all of their members on board a law and something that, and then they're pushed back very hard by schools. If you try to be more aggressive, the big universities, which have very large lobbying activities that go on, push back hard against it. One of the things we've heard is that if we do this, and I spoke with the people down in the House of Representatives today, one of the claims is that we're going to get de-accredited if we don't have DEI, full board DEI training that goes on in medical school and all of its accompaniments. And it's true, one of the LCME standards that you have to adhere to does talk about diversity and the requirement for that. And I think several of your members have mentioned the fact that this goes back a ways, and this DEI, this diversity requirement for medical schools goes back many, many years now. But it was all that they really asked for was you attempt to recruit the best and the brightest individuals from minority groups that would participate in medicine. It wasn't that you're going to go and change your standards in order to fulfill this requirement to get more individuals in. That's really the essence of what's changed, not so much the desire to have the opportunity out there for any qualified minority students that want to go into medicine. That's of course wonderful if they're really qualified. The problem now is to undermine this. So our legislative process speaks to some of these issues and an attempt to redress it.
Well, that's really
Whether a let me just say, whether a lawsuit would work, I don't know. I mean, we have very good law firms that we work with. We could certainly raise the issue there, but they really pick their spots about what they think they might be able to win, what they think people would really have standing in order to engage in a lawsuit, because it's a very expensive proposition. And, you really have to be sure that you're going to be successful before you go down that path.
Oh, of course, that makes complete sense. I really like that point about using state funds for expensive speakers, though.
Yeah.
That I think would really resonate with the public. And you do have to grow public opinion before you can pass laws like that. I completely agree. But just the idea that we have medical shortage, nursing shortage, we have a general healthcare shortage, and they're constantly proposing and trying to pass bills that are going to increase the number of clinicians out there, and that they're spending some of this money on expensive professionals who more and more people are realizing this is ideology. This is, like you say, not science. This is not turning out good clinicians. This is trying to shape thought rather than actually care for people. I think that could really help make some traction for slowing down this insanity.
Yeah, I can tell you the legislators I met with in Tennessee, they knew to the penny how much the University of Tennessee was spending on DEI. It was $3.7 million in the medical school.
Oh, wow.
Was spent on the staff. University of Michigan, there was a paper that came out in the National Review. It was $18 million for the University of Michigan on the various DEI activities that are going on there. It's just an enormous, expense with no benefit.
Very good. Yeah, thank you for that great question and for the answer there, Dr. Goldfarb. All right, we are getting close to the end here, but there are a few questions from medical students here in the Q&A that I want to be sure we get to. And one is, you mentioned a few minutes ago schools that may be improving in some ways, but are there any medical schools that are not woke, or at the very least will leave students alone who do not want anything to do with wokeness? Is that too much to ask? Are there any medical schools that are acting properly in this regard that you're aware of?
It's sort of hard to prove the negative. We know when they're out there making noises about this. We don't have all of the report cards from all the schools because we can only get this Freedom of Information Act information from public institutions that take federal dollars. That's the requirement. So we can't get all that information. I will tell. I was at a scholarship dinner in Philadelphia. I won't mention which university it was, but the leadership of the university suggested that they were getting a little fed up with what was going on and were not focusing on these issues, didn't allow gender affirming care to go on in their institutions, for example. So I think whoever spoke, I think the previous questioners talking about the reaction that is starting to occur. The legislators are seeing this and saying, what is going on here? They were unaware of what was going on. So, our efforts and other organizations' efforts to inform the public and inform these legislatures is really very worthwhile. And then any tips that you all can send to us, I can't tell you, that's been so important. When internal information is passed around and you feel comfortable in passing on to us, we can work on it in an anonymous fashion. We can make sure that no one's information is passed on through any of this, and then we can go to the media, and we can go to the legislators if it's appropriate in a state, and try to make an impact. So tips. You asked what we can do to help. That's probably the most important issue. Join us. The more members, the more the legislators will listen to our organization. As you know very well, membership is key. But most importantly is the information that we're getting and will continue to get in the future.
Very good. Thank you. So let's see. There's one comment here from a student I want to make sure we get to. And this attendee says, current MS1 here, I've noticed that our curriculum focuses a lot on health disparities, mostly in mandatory sessions that most students across the spectrum of belief systems would not elect to go to if they were not mandatory. These sessions are often branded as ethical or moral discussions. In truth, we get little education on bioethics or traditional principles, which one could utilize to approach a host of true ethical issues in medicine. They give abortion, euthanasia as examples. Wondering if you see any correlation between medical education ignoring issues like those and instead forcing students to approach and advocate for issues such as climate change, housing, and food insecurity.
Right.
So that's an interesting point. Yeah, I mean, they're taking students' attention away from maybe things they should be, like we've been saying, things they should be focusing on, and looking at things that are very tangential.
And that was sort of the whole basis for my getting started in this in the first place. Was I just saw what are you going to do about food insecurity? And I think if you ask any of the physicians who are on the webinar tonight, and you say, okay, a patient comes in and you talk to them about their medication, they say, I haven't been taking it, I can't afford it. What do? You send the patient to the social worker. Every institution has social workers that are incredibly well trained and knowledgeable about how you guide patients through a complicated society that makes it hard for certain poor people to really accomplish some of the things they need to do. As nephrologists, we work very closely with social workers. So the idea that physicians have to become the social worker is completely absurd when there is a cadre of individuals who are perfectly well qualified to function in that way, to make sure that the patients get whatever resources are available from society, from government, from nonprofit organizations that can help them through when they can't afford their medication or they can't get to the hospital or et cetera. So I just think it's so unfortunate that medical schools have taken this, because there's no evidence that that's going to improve healthcare disparities. And that really should be the only criterion for teaching people in medical school is, what are you going to do to improve health outcomes? If you're improving health outcomes, you shouldn't be teaching it.
And the other part of that question was, what about these real ethical issues? And of course, they're either ignored or destroyed. I mean, ethics in medicine is almost a thing of the past. We talk about the woke agenda being imposed on medicine. It is profoundly unethical. The gender affirming care, for example, is profoundly unethical. So you can't have a discussion about ethics unless you treat that subject honestly. And they're not about to do that now.
Yeah. It just asks, the medical students can ponder this question. How much time did you spend learning how to read the medical literature this year? I bet if they had a 1-week course, that was a lot. And yet, if you ask what's the most important thing that they're going to learn for medical school. It's how to read the future medical literature so that they can understand the implications of any therapies that are coming along. Think through what the consequences might be, both negative and positive, and understand it in a very deep and important way. And that's what a poor medical education is. That's going to be the legacy of it, is students that aren't going to be able to deal with future changes. And they're going to be the victims of the experts who show up and tell them this is what to do, whether it's pharma, whether it's other individuals in public health who tell them this is the way you have to behave, because they're not going to have the tools to really do the analyses themselves.
Sadly, we're already there.
And I'll just ask our panelists if they have any concluding comments they'd like to make before we wrap up. And thank you again for your time tonight.
I would just like to thank your organization. I think you're doing wonderful work, and I hope you keep it up. I think you're speaking out for a part of the physician workforce that really has no voice. And I think it's really wonderful work, and I urge you, and I'm glad I'm a member of your organization.
We're honored to have you. And yeah, thank you for spending so much time with us tonight. And I'd also like to thank Dr. Ammerling again for his help, and Dr. Smoots for her help. And with that, we're at the top of the hour here. Great 90 minutes. And we will be announcing future webinars here in the future. Of course, please save the date for the APS annual meeting, which is coming in up in October. You can find that information at our website. But with that, I'll go ahead and sign off. From all of us at APS, happy National Doctors Day and good night.
Good night.
Thank you
Good night,
again.
everyone. Nice, Tim.
Good night.